Welcome to the Board of Nursing Committee meeting. Today is May 17th, and we will take roll call to establish a quorum. My name is Dolores Trujillo. I am a practicing RN, and I was appointed by Governor Newsom in the direct care provider role. I am also the current president of the board. Vice President Mary Fagan will be joining us from the San Diego area, and also Loretta Melby, our executive officer. Vice President Mary Fagan.
Good morning, I'm Mary Fagan. I've been appointed by the governor in the Nursing Services Administrator role.
Thank you, Mary. Elizabeth Woods.
Good morning, everybody. Elizabeth Woods. I was actually appointed by Governor Brown a number of years ago, and I'm in the advanced practice nursing role.
Thank you, Elizabeth. Jovita Dominguez.
Good morning. My name is Jovita Dominguez, and I was appointed by Governor Newsom in the education role.
Thank you, Jovita. Patricia Nguyen.
Hi, good morning, everyone. I'm Tricia Nguyen. I was appointed by Governor Newsom for the public member.
Thank you, Tricia. Our executive officer, Loretta Melby.
I am Loretta Melby, and I'm the board's executive officer.
Thank you, Lori. And our board counsel, Reza Pejouhesh.
Good morning, Reza Pejouhesh, board legal counsel.
Thank you. We will now have the comments for the format of a teleconference call.
Good morning. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. When the board reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. In person and also at our remote locations, you will be asked if you would like to make a comment at that point too. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then move on to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. This is not a means to ask questions of the moderator or members of the board. Such inquiries submitted using this feature will not be answered. When asking a question, please make sure the question is directed at the host, me, in the dropdown. The in-person comments, the board will elect to answer at that point or not. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when board members or senior staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will interject with a brief friendly reminder.
Thank you. Before we move into public comment, I would just like to make a correction. I said we were at a board committee meeting. This is a board meeting, BRN board meeting. Also, I would like to take a moment to acknowledge Imelda Ceja Bakowitz, her time here and service as a valued board member for the past 9 years. During this time, she also served as the chair of the Enforcement Intervention Committee. She has been an advocate for change and serving the people of California. Imelda assisted new board members during their transition, was available to the public, and worked with BRN staff on board matters. She will be missed, and we wish her the best in all of her future endeavors. We can now open for public comment.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
This is Reza. I just wanted to clarify this is public comment for items not on the agenda or suggested items for future agendas. Item 3.0 on our agenda today.
Thank you. I'm sorry. Annette Rousseau, RN, would like to make a comment. 1 second, please. Go ahead.
Good afternoon, everyone. I am at an airport, and so I'm just gonna share a few websites for information on COVID and vaccinations, and if you would like to invite me to another meeting, I can share additional information. It's very disturbing that I've been studying about COVID and the vaccines for about 8 months now. And I want to share the first website is www.Fleming Method. It's FlemingMethod.com. This is a PhD, MD, JD, who has all the information you ever wanted to hear that you will not hear on mainstream media. And this FDA new ruling just a few days ago allowing 5 to 11-year-olds vaccinations is very dangerous for children. My other second resource is Dr. Robert Malone. I will read this until I get cut off, and I'm totally welcome to be cut off. Dr. Malone was the inventor of the mRNA vaccine technology. In November, he stated there are 3 issues parents need to understand. The first is that a viral gene will be injected into your children's cells. The gene forces your child's body to make toxic spike proteins. These proteins cause permanent damage in children's critical organs, their brain, nervous system, heart, blood vessels, including blood clots, the reproductive system. This vaccine can trigger fundamental changes into the immune system. The most alarming point is these damages have occurred, they are irreparable. You cannot fix lesions within the brain. You cannot repair the heart tissue scarring. You cannot repair genetically reset immune system. I'm going to stop right there. Dr. Malone does have a website, Robert, M-A-L-O-N-E. If you want more information on these scientists, there are thousands of scientists all over our country and the world that have seen the dangers of these vaccines. And if this is damaging children, just think of what it is doing to adults, because we're just big children. And it's very disturbing that other.
Thank you for your comment. Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in the HQ2?
No, there's no public comment here at the headquarters.
Yeah, it doesn't appear to be.
Thank you. Board EO Melby, are there any public requests for comments in your
No, we have no
area?
public participants here at this moment.
Perfect. Thank you. Board President Trujillo, there are no other public requests. Oh, wait a minute. Somebody may have stuck in. Hold on here. Nope, I'm sorry. There are no other public requests for comments. Would you like me to close this window?
Yes, thank you. All right. At this time, we're going to reorder the agenda. And I would like to bring 6.5, the presentation on the role and scope of the RN in aesthetic medicine, presentation by Lori Haney. Is Lori here?
She is.
Beyond the participants. Has she been elevated?
I'm here. Can you hear me, Mark?
Yes, I can hear you. Go ahead. Little bit louder, Lori.
Okay. Can you hear me now? Hello? Mark, can you hear me now?
Yes.
So a
Yes,
little
much
hard
better.
to
Go
hear
ahead.
her.
Okay, should I
Hard to
begin
hear
now?
her.
For those of us in the in-person location at the headquarters, it's pretty faint. I don't know that we have much control over that. Just to the extent you can speak close to your microphone, it may help.
Okay, I'll do that.
Thank you.
Mark, are you ready for me to begin?
Yes, ma'am. Go ahead.
Okay, good morning, everyone. I wanted to thank the board for this opportunity to present. I'm getting an echo, so I'm going to try and do it without the headphones. Mark, can you hear me better?
You still sound the same. But if you sound fine to yourself, you're.
Is it possible to fix the echo so I can hear myself better? Okay, I'll speak louder and there's just a big echo. Okay.
I don't believe
so
we're
thank you
getting an
all
echo
for
on this
allowing me
end.
an opportunity to present, just to shed
There's
some
not an echo on
light
our
the role
side.
of aesthetic medicine. We can scroll ahead. So this is who I am, just a brief introduction. We're going to go through the agenda. Next. We're going to do a brief overview of aesthetic medicine, services offered, current regulations, the scope and practice for the RN. We're going to skip over the investigative process. That was actually a webinar with a different audience. We'll touch on some gray areas. We'll skip over the investigator questions and then end with Q&A if anyone has that in the public forum. So a little bit about who I am. I've been a registered nurse for 26 years, the last 18 years consecutively in aesthetic medicine with the same employer, and an expert witness for the BRN since 2013. Love my job, passionate about my nursing role. We could go to the next slide. So let's just touch base on where med spas began. A very savvy businessman physician way back in 1999 realized that he could combine cosmetic medical procedures in a spa-like atmosphere and then coined the term med spa. And from that point on, it quickly grew that concept. But no one quite knew what to do with that. So the California Medical Board was silent until 2007, where they put forth their first public statement, which is often referred to years later. It was titled Growth of Med Spas, the Bottom Line, the Business of Medicine. It was a consumer alert. And basically it was giving a nod to the role of med spas, but with a warning to consumers and to healthcare professionals that it still was governed by current regulations. It is still the practice of medicine. Next. So growth factors, as you can see, it's been a steady increase. It has not slowed down. The global aesthetic market is $30 billion worldwide. The forecast for 2022 is 15% growth over the next 10 years, with North America having the largest share. Part of that is obviously consumer interest in self-care that's not lacking, anti-aging, wellness. We also see, especially in California, an older demographic where senior citizens are living longer, taking better care of themselves, and with that, we see an uptick in them also wanting to look better. We have, for the last 10 years, a much bigger demand for off-face treatments, meaning body work, a consumer demand for non-surgical options. Social media is a big driving interest. That could be a good thing or a very negative thing. And Botox and all of its competitors are still the #1 treatment worldwide and growing and outpacing all the other services. Next, please. Business trends. We have more non-core physicians entering aesthetic medicine. So when we refer to core specialties, that's referring to plastics and dermatology. Now we see ER doctors, family medicine, anesthesiologists, OBGYNs, a lot of different practitioners trying to get into aesthetic medicine. Multi-facility venture, private equity-backed organizations. This is constantly changing. We're also dealing with cash versus insurance-based medical practices. So follow the money. You know, wherever there's cash paying patients, you're going to see a bigger interest in the business side. What I've seen over the last several years is much more franchising of aesthetic practices and quick expansion at all costs, which I find kind of interesting with the uncertainty of the economy right now. It has not affected the world of med spas at this point. Next. So let's just talk about what we can find in a typical aesthetic practice. Skincare products, prescription and non-prescription. Those that are non-prescription, they use the title cosmeceuticals, which means they have higher grade ingredients, a little bit more pricey, but it's a big revenue generator for the practice. Versus prescription products such as Retin-A, Latisse, which is an eyelash enhancer. Neek is fairly new. That was FDA approved in February of this year. It's an eye drop, first of its kind, that actually elevates the upper lid for ptosis. Hydroquinone, which is a bleaching product that helps fade brown discoloration off the face or body. The FDA recently, very recently, made some changes where they're pulling it off the shelves for over-the-counter. And then, of course, triple numbing cream. Next. Let's talk about neuromodulators. Neuromodulators is a fancy term for medications that inhibit muscle contraction, or think of them as muscle relaxers. We have Botox, Dysport, Jeuveau, Xeomin, 4 brands with more in the pipeline. In fact, I just heard the next one just got FDA approval, Daxi. They all come with a black box warning, which is the highest level of warning the FDA can give a drug, meaning there's some serious adverse effects associated with this, including death. Must be FDA approved for use in the United States. Must be ordered within the United States directly from the manufacturer. We often hear the term in our practice bootleg Botox, and what that refers to is any type of neuromodulator that is purchased outside of the United States, which is actually illegal, or a counterfeit product where it's not even the authentic drug, which is very scary and dangerous. Unfortunately, we see a lot of that happening right now. A lot of people ordering overseas to have a better cost savings or to price it much lower than the standard. These neuromodulators must be ordered with a valid physician license, and that physician license must be directly linked to the acting supervising medical director of the practice ordering it. It must be delivered to the authorized location, so it should not be going to people's homes, and of course securely stored. Next. So let's just do an overview. Neuromodulators, #1 cosmetic procedure in the world. As we all know, Botox was the first one, and when their monopoly was let go, we had Dysport second and the others in line. Think of them as temporary muscle relaxers. They temporarily interrupt the nerve messages that the muscles need to actually contract. But you know, the body is an amazing thing, because what it starts to do immediately is want to grow new pathways or receptors to receive that message. So over a period of time, 3 to 4 months on average, the body has created enough workaround to start getting that contraction on board. We know there's clinical benefits versus aesthetic uses. Clinical would be for migraines, TMJ, cervical dystonia, muscle spasms, urinary incontinence, and also a condition called hyperhidrosis, which means excessive sweating. But compared to the aesthetic uses, obviously lines and wrinkles and actually lifting of certain muscles, there's always going to be benefits versus contraindications. There's potential negative side effects. The most common would be ptosis, where the upper lid moves down, the forehead relaxes too much, and the brows drop, and then all the way to an adverse side effect. Some practitioners use it in the neck bands called platysmal bands. We think that's a little far left of safe. We choose not to do it, but the risk of that, and we've seen it, you can have dysphagia or difficulty swallowing when that product affects the swallowing muscles. And so we are always proponents and advocates to teach the community and even ourselves that this is a medical procedure, not a commodity. So people should not just shop on price alone, but they don't know what they don't know. So we want to educate the community that it is a medical procedure. And when finding a practitioner, look for skill, level of training, and just not the cheapest price. Next, please. This is one of my patients. I love this photo because she was new to everything. She had powerful frowning muscles, and you can actually see on her right side so much recruitment over her right eyebrow that it was just out of control. And then 2 weeks later, she's attempting to frown in the below photo, and it's perfectly at rest. Not only does this look better because she looks less angry, but also you can see a lifting effect of the inner brows and off the bridge of the nose, but it actually feels better for the patient. Next, please. Okay, dermal fillers, that's the next big portion of injections. Dermal fillers aren't muscle relaxers, they're actual injectable products that offer an immediate improvement in most cases. We can simplify it between permanent versus non-permanent. Most injectors choose to use non-permanent injection products. They're a lot safer. When you deal with something permanent, if you run into complications, you're going to have a lot of challenges. There's so many brands and options on the market. We still have less than Europe, but they are constantly producing different technology, different brand names, such as Galderma, which is what we use, the biggest competitor to Allergan Botox. They could have 10 gel fillers on their menu at any given time, with more coming through the FDA. Then you have biostimulators, which are Radius and Sculptra. These are not fillers in the true definition, but they're injectable products that cause the body to make its own collagen. So an overview, they stimulate collagen, they can fill parts of the face, they sculpt, and they also provide shape. There's always going to be benefits versus contraindications. Potential negative side effects are bruising, swelling, lumps, bumps. But adverse events are what we're most concerned with as injectors. These are underreported because right now it's a self-reporting system. And, you know, everyone thinks about Botox and the black box warning, but there are far more serious and numerous adverse events happening with filler that we try and shed light on. It's very concerning, especially with the amount of people injecting without proper experience. And we're talking about vascular occlusion that could even lead to blindness and all other complications, necrosis, and so forth. And again, our message to the community is that it's a medical procedure, not a commodity. Next, please. This is a gentleman I've been working with for quite some time. He was not interested in a surgical process. He did undergo a rhinoplasty for the nose, and it did not meet his expectations. So he wanted to try filler, and he has such a great aesthetic eye for himself. He had the vision, and we worked collaboratively, but it shows you the role of different kinds of filler. So what we did is we elevated his cheeks, created a stronger cheekbone. I added filler down the nose to create a smoother line and a thinner look. You can actually camouflage the hump that he has. He wanted some lips, so we gave him some very natural looking lips for a male. We did a little bit of filler under his eye for the teardrop hollowing. And then we also augmented his jawline and his chin, kind of hidden by the beard, but you can see the balance and structure of his face was changed in a very natural masculine way, just using filler without any downtime. Next, please. other treatments that involve injections. That's a newer procedure or product, FDA approved for cellulite. It's an injection product that goes into the dimpling, and it's supposed to improve the cellulite by getting rid of the bands and elevating the tissue. Quite honestly, we speak out about Quo. We haven't seen much success. When there is success for a big price tag, the patient has heavy, significant bruising. And what we're seeing with that heavy degree of bruising for medium skin and darker skin types, they are left with what's called hemosiderin staining, which is a dark staining under the skin. When the iron in the red blood cell leaks out, it starts to live under the skin like a stain. And we only have one laser that tends to be able to break that up and fade it over time. But it's the new rage. Kybella was approved a while back, and that's an injection product. FDA approved under the chin in the submental area to help get rid of that little fatty pocket. And as you can imagine, a lot of practitioners are using it all over the face and body. We choose not to use it. Sclerotherapy, this is one we like. That's old school. It's been around for quite a while, where you use a chemical injection into veins to get rid of unwanted veins. Should only be used on the legs, never on the face. PRP, platelet-rich plasma, we can thank Kim Kardashian for putting that on the map, also known as the vampire facial. We don't use this. We're outspoken a lot about it. It doesn't mean that no one ever gets results, but there's no studies that actually prove, peer-reviewed, that there's any aesthetic benefit. It's overpriced, overhyped, but we have seen great results when it's being used in a clinical setting for soft tissue injuries. And then the hybrid of PRP, the latest thing on the market is PRF, platelet-rich fibrin, which is the same concept as PRP. Next, please. Medical devices. This is just an example of one of our most powerful, sophisticated lasers. Next. So let's talk about lasers and light-based devices. This is what I get so excited about. In a nutshell, laser is a pure wavelength of light. And when you have a pure wavelength of light, it sees something very specific. It has a target. There's only 3 things that a laser can see. That's red, brown, and water. Very simple but sophisticated science. When that light sees the intended target, it converts to heat immediately, and that heat is energy. So it's light, heat, energy. Lasers are classified for medical lasers 1 through 4. 4 is considered medical with the highest caution. It can cause the most harm to eyes and tissue, and that's what we use here. IPLs represents intense pulses of light. IPL. It's not a laser. It will never outperform a laser, but it does have a great place in aesthetic medicine for light to medium skin types, and you can cause great harm with an IPL. And then finally, LED, light emitting diodes. Those do not require a medical license. We see this a lot in veterinary practices, chiropractic, spas, where it claims to cause decrease inflammation and healing. Next, please. Love this. This is my favorite laser and our most popular procedure. In Southern California, we have a lot of brown spots, sunspots, whatever you want to call them. This is after 1 treatment. We can see great clearance of the majority of the sunspots on her face. And again, when you use heat and light, it's very healing to the skin, so we can actually see overall skin improvement, the texture, the quality, a little bit more turgor. That's what he can do besides just removing the sunspots. Next. This is a very stubborn type of birthmark. It's called a nevus of Ota or nevus of Ito. Most practices will not take these on. Either they don't know how to treat it or they don't have the right technology. We have one laser that is proven time and time again to have the power to penetrate where those cells live. And the reason for the color like this is because where those cells of color live, they live deep enough that it gives kind of that bluish gray hue under the eye. They call it a robin's egg color. And we can actually remove this without any downtime. There's no breaking of the skin, which I think is nothing short of amazing. Next, please. Cosmetic ink. Unfortunately, with the popularity of cosmetic ink, we're seeing a lot of women that want it gone. Whether it's eyebrow, eyeliner, lip liner, we can remove it all. It's no different than removing a decorative tattoo, but cosmetic ink is a little temperamental. So having the right know-how is important, but it's very rewarding to get rid of that unwanted ink. Next, please. Same laser that we use for cosmetic ink is the same laser for decorative tattoos. An alternative to lasers which are FDA approved for tattoo removal, we have a lot of consumers that are relying on non-medically licensed people to use saline injections to pretty much dig out and leach out the ink. Very painful, high risk of scarring, repetitive treatments. And again, lasers are the safest, most sophisticated way without breaking skin to remove the ink. Next, please. Rosacea. Rosacea just means facial redness. It's chronic. There's no cure for it. This woman in particular, I wanted to profile. Her case was so advanced. She was not responding to typical oral topical medications that the dermatologists were prescribing. Her skin was so painful and so irritated. She could only stand water on her skin. No moisturizer, no sunscreen. So it just created a vicious cycle. So she tried lasers for the first time with us. We used a group of lasers that can actually see the redness or the red blood cell causing the redness. And after a series of 8 treatments once a month, you can see skin at rest. Her skin has healed itself with heat and light. We can see better quality, hydration, texture, of course, and the redness is gone. Next, please. Spider veins, very straightforward. We can use lasers for these little ones, and then we use sclerotherapy for the bigger ones. Next. Stretch marks. A lot of people don't know there's treatments for stretch marks. We never say we can make them disappear because it's like a scar in tissue. This is a young woman. Usually the red ones are the younger, newer ones. And after a series of a laser treatment that targets the redness just like rosacea, we can not only fade the red, but we can improve the texture and quality of the skin as well. Next, please. It's not the tattoo we're looking at. We're actually looking at the brown stretch marks around her tattoo. Gone are the days where people used to believe you could not treat dark skin safely. That's absolutely not true. If anyone nowadays says that, they either don't know how to treat darker skin or they don't have the right technology. And we safely remove the stretch marks while leaving the tattoo intact. Next, please. Again, safe removal of hair. This gentleman, real common with darker skin types, he had so much trauma in the neck and face from ingrown hairs. We call it hair bumps, a lot of scarring, a lot of pain. And we did a series of hair removal treatments with a laser that's ideal for his skin type. And you can see how the skin can heal itself when we get rid of the constant irritation. Next, please. Love this photo. This patient underwent a brachiopexy, which is a surgical arm lift after losing a lot of weight. And she was so disappointed. A lot of times patients forget you might reach your goal, but you're going to have a scar that's there. And so she had a scar that just wouldn't calm down after time. It was very ropey and rigid, very itchy. We can also see all the little tiny spider veins coming off the scar line and a lot of redness down the scar line. So we use Kenalog, which is an injectable steroid, to flatten out the scar and debulk it, followed by lasers to get rid of the spider veins that's feeding the scar and pull out the redness. And this is her after a series of treatments, and now she can wear whatever she wants. Next, please. Again, profiling that we can safely treat dark skin. There's a certain group of lasers that just love skin like this. Terrible acne, but a lot of scarring, which is what medium to darker skin types do. They hyperpigment, and no downtime laser. We helped with the acne and improved the skin. Next, please. Warts. A lot of us don't know that warts can be treated with lasers. You know, there's a high fail rate for traditional dermatology where they attempt to freeze it off. That's painful, usually causes blisters, and very superficial. Oftentimes it doesn't solve the problem. For plantar warts that are really problematic, sometimes the patient will undergo surgical excision, which is extremely painful, downtime, and oftentimes they come back. So in our practice, we actually use 2 different lasers. One laser for the wart, and this was after 2 treatments, no downtime. And if and when it comes back, we'll treat it again. Next, please. Love this photo. So we've had the most attention on this photo in our practice in social media. We do recognize and acknowledge that there's different lighting between the before photo and the after photo, but that's actually how the patient photographed herself at home. She was so thrilled that she wanted us to use her photos to show the type of results she got. So this represents the most advanced deep laser resurfacing around. This is after one treatment. She had a lot of sun damage growing up in Hawaii, and in the after photo, this is her at home a month later, completely healed with a whole new canvas. Now, this is a big bad boy laser. You're going to have 2 weeks of downtime, and oftentimes we hear patients say they don't want downtime, and we tell them you're not going to get these results without accepting downtime. Or more often than not, they'll say they underwent laser resurfacing elsewhere and they were disappointed. There's numerous devices on the market. Every practice has one version. It's not that one's better than the other, but we're always going to preach it's how you use it that matters, and we use it to the best of its ability. Next, please. For non-laser energy devices, heating. We can accomplish heating with ultrasound, such as L-therapy. We can also use radio frequency, and there's all different types of radio frequency now. It's kind of like, again, the new kid on the block. They combine it with monopolar, bipolar, with microneedling, with fractionated. It's just endless, but they all generate heat, and there's still the same warnings. We've seen some terrible tissue injuries from uncontrolled heat under the surface of the skin, so there is still risk versus benefit. Next, please. Energy devices that use cooling, cold therapies like Cold Sculpt. You can have non-licensed, non-medical staff. They undergo training by the manufacturer, and this is a perfect example of how technology has surpassed current regulations. The last time I heard a gentleman from the FDA that works with medical devices speak on this, he said they do recognize that cold devices need some type of regulation, but there's just no language that currently addresses that. Next, please. Miscellaneous microneedling, everyone hears that. It's cheap, it's done everywhere. It's not that it's a bad option, it's just you have estheticians doing this, which is illegal. It's not within their scope to do it, but they're using it for anything under the sun, and we just think that's not good medicine. And then threads. Most of you have probably heard about threads, also known as the Lunchtime Facelift. This was actually popular in the early 2000s, and it was banned by the FDA because of all the complications. So several years ago, manufacturers realized, well, why don't we rebrand it, heavy market it, and use a safer product? So the newer threads, Pdo Threads, it uses a dissolvable surgical suture. And the issue I have with this, I think this is the one procedure I'm the most outspoken about. And when I say that, I don't mean that there's never any benefit, that whoever uses it is not safe. I have many respected colleagues that do this, but I have to look at the whole picture and everything that goes in the pot. It's high priced. It has the highest complication rate in aesthetic procedures right now. That's a little scary. And I think that is in part because you have so many nurses and doctors doing it that think they can do it well and shouldn't be doing it. And what we see happening when patients come to our practice for help, there could be rippling in the skin, atrophy of the skin, heavy bruising, infection, and also the threads poking out from under the skin and then need to be manually extracted. Let's just say somebody gets a really good outcome with no complications. Then the idea is that you're going to have this suture dissolve in the first 6 months, and that magically your body made collagen all around the suture to hold everything up in place, and that will last up to 2 years, and we just don't see that. Next, please. Resources to determine scope of practice. There's a lot of gray areas, a lot of confusion with nurses in aesthetic medicine. And I always say, you can't plead ignorance. You have to do due diligence to find out how to work in aesthetic medicine safely and within your scope. Board of Registered Nursing is an excellent source. That's who I contacted in 2005 when I started working here. The medical board gives some guidance, the Nurse Practice Act, Business and Professions Code, and existing corporate law and precedent. Next, please. So to stay in the scope of practice for me, on all RNs, we have to work with appropriate physician supervision, and the key word here is appropriate, an approved healthcare facility, and as you might expect, even that definition is hotly debated. Standardized procedures, which we're all familiar with, it helps me to work with autonomy and stay within my scope. It's a legal framework. And of course, a good faith exam, even that has been hotly debated, but I think it's pretty black and white now. That can be done in person or telemedicine and must always be done before a medical procedure may continue. Next, please. Physician supervision of the RN, and of course everyone likes to slice and dice this, but the basics are the physician must be currently licensed in the state of California, no lending out his name and license from across state lines. He or she must be majority owner of the shared practice, 51% or greater. What we look for when we're investigating cases is a visible presence on site. Is the doctor on the signage, the website? Do they have a visible presence? Skilled and knowledgeable. So if the physician is going to claim appropriate supervision, he or she must also be skilled and knowledgeable in the services that they're supervising. We want to see ongoing supervision through evaluations, observations, meetings, must be collaborative work, must be immediately accessible via telephonic means if not on site. Physical proximity, also gray areas, is not defined but must be considered reasonable. And then of course the backup plan if the supervising physician is unavailable. Next, please. Mid-level extenders, that refers to a nurse practitioner or physician assistant, must be licensed in California. They work with much more autonomy than an RN. They can actually perform the good faith exams. And now kind of a gray area that we've seen over the last several years, you have third parties that hire themselves out to perform the good faith exam remotely. The concern is that they have no relationship with the practice other than this contractual agreement. The NP still must have standardized procedures, but they can prescribe. But they also have to be skilled and knowledgeable with the services, and there's limitations on how many PAs or NPs the physician could provide supervision for. So this becomes more of an issue when you see a physician that is the director for 8 different med spas at any given time. Next, please. Approved healthcare facility. This is something that's been a big issue in recent cases. I'm trying to offer definition. We can look to the Health and Safety Code 1250, and the language is very vague, but it does refer to organized, maintained, and operated. And within those descriptions is where I like to insert information with trying to define that. Next, please. Okay, so this is also something that I've had to go toe on. What is not an approved healthcare facility? And again, the language can be a little vague. Now, I recognize that the law does not dictate where physicians can practice medicine. I'm only given opinions on the RN. Private residence, Botox parties, not appropriate and not legal for RNs. Hotel rooms, unfortunately, that's becoming more popular. Business offices, hair salons, mobile units, a van. We're seeing vans offering this kind of a concierge service, and health clubs. Now what we are having are physicians that actually run their concierge service, and that's something that's still yet to be determined. Next, please. Standardized procedures, I'll go through this quickly because most of us know what they are. Mandatory when a physician is not present, must be available on demand. Oftentimes in cases that we're looking into, nobody knows if they have them, where they are, or what they say. It is a legal document, it's not an option. It provides an outline for policies and protocols, but it does not replace policies and protocols. It must be on site, periodically updated. Again, it doesn't specify is that yearly or every other year. It does say periodically or when there's a change. Also, one thing that's been debated is signed and dated by healthcare team. Unfortunately, it calls that out for nurse practitioners, but it didn't say that for RNs. And so we have some nurses and doctors trying to point to that little loophole and gray area. Next, please. Who can use operate medical devices and administer prescription drugs. So remember, that's going to be filler and Botox Dysport. A licensed RN, yes. NP, yes. Estheticians, no. And we're seeing rampant esthetician using medical devices and even injecting. Technicians, no. In other states, you could be a licensed technician, but not in California. LVN, no. Medical assistants, no. Next, please. Good faith exam. It's a mandatory medical history. They're trying to clear the patient medically to approve the treatment plan, and it must be done before. It's prior, so some people call it a prior exam. It's not appropriate for the doctor to look at photos or do a chart review. There has to be interaction with either the mid-level extender or the supervising physician. We like to use a laptop because there needs to be interaction, a visual interaction. And we also ask that they consent to telemedicine. They know exactly what the good faith exam is for. It's recorded in the patient chart, and it should be updated when there's a change to the treatment plan, change in patient health. In our practice, we like to update it every 2 years. Next, please. This is a typical filler syringe with a label. This is what a gel filler looks like. It comes sterile in a package. Next, please. So summary for aesthetic medicine working in the scope, good faith exam, physician supervision, standardized procedures. Get that and forget the last two. That's for the webinar for investigations. Next, please. Consultation. Who's qualified to perform a consultation? Anybody that works in the practice, doesn't have to be the nurse or doctor. We talked about a good faith exam. We addressed all of these. We can move on to the next slide. We could go to the next slide. Gray areas still vague regulations, and I'm hoping that the board will work with the medical board to tighten up the gray areas and the loopholes of inconsistent language between how the NPs work versus the RNs, a lack of accountability. And I do know in a lot of cases I review, the RN pleads ignorance. And sometimes I feel badly for them because they're doing what the physician told them to do, and they always believe, well, that's safe because the physician instructed me to do this. But that doesn't hold up. We need to hold our profession to a higher level of accountability and training. I recognize that technology is outgrowing regulations at a rapid pace. Consumer demand is driving medicine versus science, and this is very concerning. I've been in the practice long enough to realize back in the day you would have the manufacturers reach out to the doctor or the practice to present their technology or product and use evidence-based science to convince us why we should consider this. And now what they do is they promote it on popular TV shows or social media to get the consumer to drive the demand. So it's a little bit more backwards. We're dealing with concierge aesthetic nurses that are showing up all over the place to do medical procedures. That's concerning. We could go on to the next one. Okay. Not sure if we have time for Q&A. Mark, what would you like to do?
Board President Trujillo.
Thank you, Lori, for that great presentation. There was a lot of information in there. Are there any questions from the board? I have a couple of questions. What is, when you hire somebody, let's just say an injector, what is the educational requirements other than, I mean, that they have their VRN, but is there any other CEs, training, and how do you keep up on that training?
I heard the first part of the question. When somebody's getting an injection of filler, what was the second part?
Let's just say as an injector that is on staff
speak up a little bit more?
at a med spa.
Yeah.
Can you hear me? Can you hear me, Lori? No? Okay.
I heard heard injection at a med spa, and I'm not sure what the last part
Can
was.
you maybe disconnect your headphone and put it on speaker?
I'm sorry. Mark, can you tell me what the question is?
Mark, can she disconnect her, does she have her headphones on? Maybe disconnect and put it on speaker?
Can you hear now with your headphones unplugged?
I can hear you, Mark. What was the question?
I was just asking, for instance, an injector that is on staff at a med spa. It seems like there is an increase from what I've seen on social media and advertisement, a lot of injection type of therapy. How do you keep up on the educational requirements for that, and what do you look for as far as training when you hire someone?
That's a really good question. And unfortunately, it's kind of like the wild, wild west and has been because there aren't any state mandated testing or schooling for this. And I know in other states they're looking into that or they have mandatory testing. But in aesthetic medicine, mostly it's on-site training. The manufacturers will offer a lot of training and supplement that. The challenge with the manufacturers doing the training, they can't speak or teach anything off label. And a lot of what we do is off label, which is completely fine. It's the standard in the community. So they will have to contract with a third party to come in and be able to train that way. But nobody's regulating or monitoring it. And I know the BRN and the DOI has been very involved in trying to track how social media is advertising these services without any physician involved. And all we can do is really drive the message to the consumer that these are medical procedures, you know, especially the younger crowd. They're heavily influenced by what they see on social media. And I'd like to see our nursing profession hold ourselves to a higher standard. But until then, we got to tighten up the regs and make it a little bit more clear. There's really no way to verify someone's training.
Okay, thank you, Lori.
Thank you.
Any other questions from the board?
Dolores, this is Lori.
Thank you, everyone. I appreciate your time and
Thank you.
attention. Thank you.
Dolores, are you able to
Mark,
hear me?
can we
This
open
is
it for public comment, please?
Did you hear Lori?
I'm
Dolores?
sorry, no, I didn't.
I just wanted to check in with Betty. This was a presentation that Betty had requested on med spas and nurse practitioners and the board's role. And I was wanting to know if Betty had any additional questions or if this satisfied her request. Was there any concerns that this presentation brought up regarding to the advanced practice role?
This is Betty, and yes, the presentation was great. Those were the things that I was hoping to hear. Thank you.
Thank you.
All right, seeing as there's no further questions, Mark, can we open it up for public comment?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. Lori Haney, on your screen on the bottom left corner, you can turn on closed captioning. So if you can't hear, you might be able to see the question being asked.
Thank you.
I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in HQ2?
There doesn't appear to be, Mark.
Thank you. Board Member Fagan, there are no public requests for comments on the WebEx nor at HQ2. Are there public requests for comments in your area?
There are not.
Thank you. Thank you, Lori. Good job.
Thank you very much.
Thank you, Lori. That was a wonderful presentation.
Thank you.
Moving on, we are reordering the agenda one more time, and we are going to hear a report out from Dr. Ray. Is Dr. Ray present?
Sorry, I'm looking. I have a Ed. Let me see if that's him. I don't have a Dr. Edward Ray. Let me see. Hold on. Dr. Ray, is this you?
Board moderator, this is Lori. I did see that Samantha Gamble's bar is on, so if we're not able to find Dr. Ray, it would be appropriate to elevate her. And this would be for agenda item 7.1, Nurse Practitioner Advisory Committee updates, information only.
Okay, I do not see Dr. Ray. I did promote Samantha Gamble's bar.
Go ahead, Samantha.
Oh, I'm sorry. I'm at work, so my apologies. Good
That's
afternoon,
okay.
members of the board. Thank you so much for giving me the opportunity to have this update for you guys. I'm kind of going off the fly because I don't have my paperwork sitting right in front of me. However, during our meeting earlier this month, we did have a presentation of regulatory language as it relates to moving forward with AB 890. There were a couple of things that were discussed as far as points of interest from the members of the public. The first thing had to do with requiring a signature for referrals, if you were going to be making referrals to one specific physician as a backup plan. That information was thought to be a little too stringent, and so the committee decided, voted, and that portion was removed from that regulatory language. The additional part of discussion that we had was related to the attestation forms that nurse practitioners will need to obtain as part of the process of AB 890. And so there was some discussion about family signatures and financial attachments. And so there was no acute change in that portion of the regulatory language, as that is already part of the practice at the BRN, and we wanted to stay primarily in alignment with that. And so therefore, with those two modifications, the Impact Committee voted to move forward with giving that information to the committee, to you guys to overlook and to potentially move forward with either accepting those or giving any additional modifications, and then moving forward with having opportunity for public comment. the only additional thing, we had to move some things around because there was a lot of discussion about regulatory language, and we wanted to give the public a lot of opportunity to give input at that point. And so we have moved forward with sending that information to you guys, and we are just simply waiting for the additional information as that stands. I think the only thing that we will need to, we'll be discussing with the committee next is our next update as it relates to OPES and where they are in looking at the examination and certifications for nurse practitioners currently in the state of California. And that is primarily the gist of everything, I think, just off the top of my head. I apologize. And so I just wanted to make sure I was on here, today. So I'm glad I was here. I guess at this time, I need to ask if there's any questions or anything that I missed that from EO Melby that she can remember, or anybody else on the call that was there.
This is Betty. And when is your next meeting, and what are you going to be dealing with at your next meeting?
Our next meeting is in August. I'm anticipating us having some discussions about OPES, as well as any the funding and the fees that may be associated with from the BRN aspect, as far as additional labor that may be needed and additional fees that may be incurred by nurse practitioners as it relates to AB 890. So that will be the next discussion. And then any additional information, because I think within that period of time, the 45 days, depending on how things move with the regulatory language, we could then end up having more discussions about regulatory language and then giving additional recommendations for you guys to overview.
Do you have any sense of how long it may take to have the language formalized? Completely formalized.
I think that was one of our primary concerns during this meeting. I think what we have right now is a good blueprint at this point, and that's why we voted to move it forward for you guys to review. But I think that will really depend on the next 45 days if you guys are in agreement with what is written in the regulatory language right now, or if you feel like there's things that need to be addressed. And then give more opportunity for public comment as well, because I believe that time frame is 45 days. And so I think I think it really depends what's going to happen in the next 30 to 45 days as far as what we will be really concentrating on in August, because as we all are aware, we're looking at January 2023 to make sure that this law is ready to be fully implemented, because that's the goal as written within AB 890.
Thank you.
You're welcome. Thank you. Any other questions?
Any other questions from the board?
This is Reza. I just wanted to, continuing on that last question, Betty, as far as the timing and the process, we're going to be talking during this meeting specifically about the current version of the proposed text, and we'll have our regulatory counsel who can talk a little bit more about the process going forwards and the timing and all of that. Samantha did mention the 45-day public comment period once the regulation the proposed regulation is published and noticed, and that's correct. And depending on the comments and how the board receives them and whether changes are deemed necessary or not, it could change the way things play out. So that will be something we will be talking more about today.
Any other additional questions?
Any additional questions from the board or people who are present? Okay. Seeing that there's no other questions, Mary Fagan, are there any questions on your side?
No questions here.
Okay. Thank you, Samantha.
Thank you, guys, and happy belated Nurses Week to all of you guys.
Thank you.
Mm-hmm.
Mark, can we open it up for public comment?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
Mark, as they are making the motion to do public comment, I did want to give a quick update from OPES. And with OPES, they let me know that the occupational analysis project has been completed. The report has been drafted. The national review project, all non-disclosure agreements have been signed. All certification providers have uploaded initially requested information to the secure portal. They have followed up questions and they'll continue to distribute those both in May and June. 3 of the 11 psychometric review reports have been finalized. The remaining 8 reports are being finalized by test specialists. The linkage study workshops have been completed, and they will be reaching out and gathering information from physicians in June. And they said that the release of reports and recommendations that they will provide a memo summarizing the recommendations at project completion. The California Occupational Analysis Report will be released with the recommendation memo. And additional project information may be released adhering to the above mentioned NDAs, which is the non-disclosure agreements. So I wanted to give that update and see if any board members had any questions on that, and then the public could make comment or question on that as well.
Thank you, Lori. Any questions or comments from the board on what Lori just reported? Okay, how about Mary? Is there any questions or comments on the report the short report that Lori just gave?
None here.
Okay. Mark, can we go to public comment, please?
Okay, Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments in HQ2?
I don't see any.
Okay. Board Member Fagan, are there any public requests for comments in your area?
No.
Thank you. Board President Trujillo, there are no public requests for comments in all 3
Thank you,
areas.
Mark.
Would you like me to close this? Thank you.
Do we have Dr. Edward Ray present now, or to do the report out? Of the Nmac committee?
So Dolores,
Vice
real
Chair.
quick, just for some clarification, Dr. Ray is the vice chair of the NPAC committee, and Samantha Gamble-Spar is the chair of the NPAC committee. So he would not need to report out, and additionally, I'm still not seeing him on the attendee list. You could go back and start with the agenda as at the beginning if you choose to now. Or you can take the Nmac update, and I would be providing the Nmac update as the chair and vice chair were not available for this meeting. It's up to you.
Would you like to do the Nmac update now?
We could, and then that way we can just close this out. So you would like to proceed to the next agenda item?
Yes, and then we'll go back and do the agenda as ordered.
Great, thank you. So just a real brief update on the Nmac committee. They met the same day as the NPAC committee. It was our first in-person committee meetings to be held in Sacramento since COVID came out. And so that had a little bit of technical difficulties for the first about 15 to 20 minutes, but we were able to progress forward. We did have a quorum, and there were discussions and motions held. The majority of the meeting was focused on updating the website, updating materials to remove the physician supervision aspects and the standardized procedures aspects. They were making statements that they were having difficulty getting privileges at hospitals and billing insurances because of the information on the website. So Macaulay Fusarins, the chief of licensing, who also serves as the liaison to those committees, worked with the chair to get documents pulled off our website and adding frequently asked questions. And we'll be developing a separate section within our website that has all of the practice information specific to each advanced practice role. And we'll continue to work with that. Another bit of good news was released at that meeting. There was a listserv notice that went out letting the nurse midwives and the nurse practitioners know that they now have access without a physician sponsor for the California Department of Public Health genetic screening portal. And so that they will be presenting at an upcoming meeting so that they can do kind of an FAQ or show and tell of the new portal system that they developed. So in a nutshell, that was what was discussed at the Nurse Midwife Advisory Committee. Then they will also be scheduled to have an upcoming meeting, I believe, in August as well.
Thank you, Lori. Any questions or comments from the board? Betty? There are no questions or comments from the board. Mary, are there questions on your end?
No questions here.
Regarding the report up? Okay. Thank you. Can we open it up for public comment, please?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and will move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments in HQ2?
None here.
There are no requests or comments from H2.
Thank you. And Mary, Board Member Mary Fagan said there are no public requests for comments in her area. Would you like me to close this window?
Yes, thank you.
Thank you.
All right, moving back to the agenda. Review and vote, item 4.0, review and vote on whether to approve previous meeting minutes. These are the meeting minutes for February 16th, 2022 and March 24th, 2022. I would like to make a motion to accept the minutes from these 2 meetings. Do I have a second?
I'll second, Betty.
Thank you, Betty. Can we open it up for public comment, please?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments in the WebEx. Are there any public requests for comments at HQ2?
There are no public requests for comment in HQ2.
Board Member Mary Fagan, are there any public requests for comments in your area?
No request for comments.
Thank you. There are no public requests for comments. Would you like me to close this window?
Yes, please. Thank you. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Elizabeth Woods.
Woods, yes.
Jovita Dominguez.
Jovita votes yes.
And Patricia Nguyen.
Nguyen, yes.
Thank you. Motion carries. Moving on to item 5.0, BRN future priorities and proposals for review and possible action. This is item 5.1, consideration of public comments, discussion, and possible adoption of modified proposed regulatory text to amend California Code of Regulations, Title 16, Section 1450, Definitions, and Section 1456, Continuing Education Courses. Is Heather Hoganson elevated? Or Heather Hogan?
Yes, thank you. Heather Hoganson here, your regulatory counsel. This is the first of a couple of different packages we have for regulations today. 5.1 is the continuing education courses. And as you may remember, we had a 45-day comment period in October, November, December. That comment period closed, and we did have a couple of comments which are provided for you in your packets. We have taken a look at those and have some proposed responses for you, as well as some options for changing the regulatory text. We believe that the commenters raised some valid points and would like to respond to those inquiries by making the regulatory text more clear. The draft is in your packet as well.
We're having a hard time hearing you, Heather.
Oh, okay. Let me turn up my volume 1 second. Is this better?
Yes, much better. Thank you.
Great. Okay, so in 1456, the definitions, we have proposed some additional language. One of the options was we had suggested that regarding the use of the term drug, that if a drug was going to be used as an experimental procedure or treatment, and the comment that we received was, what about a device? And so we did some research and we did find other statutory language that referred to drugs, biological product, or device, because there are some biological products that can be used in an experimental treatment or procedure. And so we have suggested that language. Next, we were also asked about some clinical trials issues, and so we have inserted some proposed language for your consideration regarding research approved by an institutional review board. And that's on the Federal Register side. There was a question about whether telehealth should be considered a treatment for direct patient care in that definition. Based on our research, we do not think that that should be defined in direct patient care because it is a modality, a way of delivering care. It is not care separately. And then finally, in the area of whether or not something is generally accepted as an experimental procedure or treatment, we have some suggested language regarding the safety of things, that if there is published literature out there that says that something is not safe and effective, that should be the tipping point as to when it should not be offered for continuing education. So are there any questions on either the comments or the proposed text?
There are no questions or comments from the board.
This is Reza. So I just want to make sure that the context of the discussion is understood. So Heather explained what's kind of going on, but just to be totally clear, the proposed text for these regulations was noticed and made available to the public. Members of the public had an opportunity to submit their comments, and we received some from I think it was California Hospital Association and an organization called Heartbeat International. So what's in the materials is their comments, some proposed changes in response to those comments, and as part of the process, the BRN is required to respond to those comments. So also in the materials is the proposed responses to those comments. So if the proposed changes and the proposed responses appear acceptable, you can make a motion to approve this, and Heather can maybe help you with some more specifics as far as the motion that's needed, and then from there we can take some input from the public and go from there.
I'd like to ask what Heartbeat International is.
Sorry, you're asking what is it?
Yeah. What is the organization?
I of course don't speak for them, but from what I know, they are an organization that it's a hopefully fair to say it's a pro-life organization. They try to. I guess I would call it, again, I think it's fair to say they're an advocacy organization that supports pro-life policies. They are also an approved BRN CE, continuing education provider. I believe the course that they offer, or courses, again, I don't know the details too much, so please don't take this with a grain of salt, but I think the courses that they offer have to do with abortion pill reversal, or something along those lines. So, but that's the general kind of nature of Heartbeat International, as far as I'm aware. Mm-hmm.
Any other questions or comments from the board? Any questions or comments from our audience? All right. Heather, you may have to help me on this, but I would like to make a motion.
Sure.
to-
So the possible motion is on the screen right now, but it would be to approve the responses to comments that we've proposed in front of you, and then approve the proposed modified regulatory changes to amend sections 1450 and 1456 of Title 16 of the California Code of Regulations, to read as shown in the board materials, to notice the proposed text for a 15-day comment period, and if after the 15-day public comment period, no relevant adverse comments have been received, to adopt the proposed regulations as noticed and authorize the executive officer to submit the rulemaking package to the director of the Department of Consumer Affairs, to the Business Consumer Services and Housing Agency, and then to the Office of Administrative Law for review, making any technical or non-substantive changes needed to the proposed regulation to complete the rulemaking process.
This is Reza. Moderator, is it possible to adjust the size of the screen share?
It's hard to read.
So we can see the proposed motion a little better.
Jen, are you able to adjust that?
Does not appear to be an option.
Okay.
I can read it again if you need.
This is Lori. For the person that has the computer that is running the screen, they can go up and adjust the font through the computer that is running the projection on the screen itself in that location. It does not have to be done from the BRN moderator.
It's with the font adjusted on our end. It's just cut off.
It's cut off.
Oh, it
The
cuts
box
it.
that it's in is too small. We need the. Right now, I'm looking at myself on the screen. That box needs to be smaller. Okay, I'm being told they maybe don't have the ability to adjust it. So maybe if we could, just have Heather read the motion, the proposed motion, a bit slower, and Dolores, if it sounds appropriate to you, you can just adopt what Heather is saying as your motion. If you have any questions about it or want to hear it again, please let her know.
Go ahead, Heather.
Okay, so the motion would be to approve the responses to comments, to approve the proposed modified regulatory changes to amend sections 1450 and 1456 of Title 16 of the California Code of Regulations, to read as shown in the board materials, to notice the proposed text for a 15-day comment period, and if after the 15-day public comment period, no relevant adverse comments have been received, to adopt the proposed regulations as noticed, and to authorize the executive officer to submit the rulemaking package to the Director of the Department of Consumer Affairs, to the Business Consumer Services and Housing Agency, and then to the Office of Administrative Law for review, making any technical or non-substantive changes needed to the proposed regulation to complete the rulemaking process.
Thank you, Heather. I would like to adopt the wording of this motion as Heather stated.
Wynn, second.
We have a second from Patricia Nguyen. Can we please open it up for public comment?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
while we wait, I'll just mention that proposed motion is in the meeting materials. It's at page 10 of the materials for item 5.1, in case you need to see it. That was available to the public as well.
Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments in HQ2?
I don't see any requests for comments or questions.
Thank you. Board Member Fagan, are there any public requests for comments in your area?
Nope.
Thank you. Board President Trujillo, there are no public requests for comments in all three areas. Would you like me to close this window?
Yes, please. Thank you. Okay. We will vote on this motion. Dolores Trujillo votes yes. Vice President Mary Fagan?
Mary Fagan, yes.
Elizabeth Woods?
Woods, yes.
Jovita Dominguez?
Jovita, yes.
And Patricia Nguyen?
Nguyen, yes.
Okay, the motion carries. Moving on to item 5.2, and this is Heather again. This is a discussion and possible adoption of proposed regulatory text to add California Code of Regulations, Title 16, Section 1410.5, regarding course requirements in natural sciences, anatomy, physiology, and microbiology courses with a laboratory component for endorsement applicants. Heather?
Thank you. So the addition of section 1410.5, which would be a new section, would address the endorsement process, as you've mentioned, so that RNs who are licensed in another state who come into California to be licensed may not have to take the lab coursework. This has apparently been a long time barrier for people coming into California to be licensed. Right now, if someone from another state came in and did not have that coursework, they would be denied licensure until they completed that coursework. And the board had voted in December of 2021 to review and update the education requirements regarding microbiology. And after looking at the coursework requirements, the proposed language here requests that anatomy and physiology also be added to that list. And so the proposed language is in the board materials. It would basically say that someone who is licensed in another jurisdiction who is applying for licensure in California, if they have been in good standing for more than 2 years, and that means they've not been subject to discipline, basically. They haven't been on probation or suspended or public reprimanded. They would not have to retake any anatomy, physiology, or microbiology courses that include a lab component, which is the normal requirement as part of their nursing education preparation. And if you wanted to make any changes to that language, we could do that now. If you would like to adopt it as is, we would adopt and prepare it to go out to a 45-day public comment period pursuant to the regulatory practice.
I have a question about this.
Mm-hmm.
Would you explain the 2 years that you spoke about? Does that mean that they have to have taken the course within 2 years of applying for a license?
It's if they have been practicing in their other jurisdiction for 2 years, so it's not like they could get licensed, say, in Kansas, and after a month come here to California. They would have to have been practicing in their other jurisdiction for more than 2 years without having any negative impacts on their license, discipline, essentially.
I'm still a bit confused with this. Are you saying that if they haven't had the course, but they've been practicing for 2 years someplace outside of California, they would have to then, applying for license here, If it was more than 2 years, they would have to take a course over again?
No, no. So this would be if, so again, say they got their license in Kansas and they've been practicing in Kansas as a nurse in good standing, no discipline, for more than 2 years, and they decide to come to California, because who doesn't want to live in California? And right now, according to Regulation 1426, they would have to take a lab course in anatomy, physiology, or microbiology. If the courses they had taken to get licensed in Kansas did not include that lab component, right now they would have to stop the licensure process and take a course that involved a laboratory component before they could finish the process here and get licensed in California. We're saying with this regulation, we would provide a little carve out and say, hey, if you've already been practicing for 2 years in good standing someplace else, you don't need to take that lab portion.
This is Reza. So the 2 years is not a requirement that the course that they took in their state was within any certain time frame. I think the idea is that if they were licensed in another state and they didn't take a lab component as part of the courses pursuant to their own state's requirements, then by practicing in good standing in their state, they've kind of demonstrated, some competency for us to be able to say, okay, we'll let you in without having taken that lab component that we otherwise normally do require. So they can have taken their microbiology course in Kansas 20 years ago. Mm-hmm. And as long as they were practicing in good standing there for 2 years, they can endorse into California under these proposed regs.
Any other questions, Patricia?
Thank you very much, Heather. That's a very detailed proposal. I appreciate it. I just wonder if you know how many states do require this lab component as part of the, licensing that, we're going to kind of grandfather in.
So this is Lori. I'll try to jump in and answer that. We don't have specific statistics on the state-to-state educational requirements. We are reaching out to get all that information, but I could give an example to one of our neighboring states, which is Arizona. Earlier last year, we were contacted because Arizona State University was getting students who had completed their nursing program, they were being denied licensure into California. And so they reached out to the licensing staff, they reached out to board ops, they reached out to myself, and we were trying to figure out why they were getting denied. Well, come to find out, Arizona does not require anatomy and physiology and microbiology with a laboratory component. They are required to take those courses, but they do not have a laboratory component. So those students who are graduating from Arizona State University were not able to get licensed in California. So we met with that program director, we shared the requirements that California has, and they were going to put a caveat onto their website that stated if they were going to go and be licensed in California, that they were recommended to take a microbiology with lab or an anatomy physiology with lab so that they could then qualify for licensure in California. That's an easy fix for students that are currently enrolled and currently involved in academia. What was really facing an issue here is we are getting, hundreds of applicants a month who we are turning away and giving them what we call deficiencies. And those deficiencies are in coursework that is required for licensure. On those deficiencies, they're denied licensure. They are then allotted time to go back to school, and like the example Reza gave, 20 years later, and even though they've already taken a microbiology course, they are now required to take a microbiology with lab course, and they then, once they pass it, are able to submit that transcript with proof of education to our board, and we are able to license them by clearing that deficiency. that has been a long time standing. I brought that forward in the November board meeting, that this was an issue that we were experiencing, especially with allowing for people to come into the state. And so that's when the board voted to address this. And this is the language that came out from that. Each board of nursing has their own scope of practice. They have their own education requirements, and additionally even have their own requirements on whether or not a background check is done or fingerprinting is done. And that is why it makes things very difficult to manage from a national level versus a state level. So I do have a research project that is in process to get this information to you, and I could bring that to an upcoming board meeting as soon as that research project is completed, so that I will be able to share out what licensing requirements are, including education, from state to state.
Thank you very much.
Why do we think that this is so important to keep this as a requirement here, this lab, microbiology, microlab?
So there was public comment received in November when that question was brought up. In our nursing programs here in California, that is part of their required curriculum. And they shared that the laboratory component was imperative to the students' learning, to be able to get the didactic theory component with a laboratory component so they could see it hands-on when they're doing, growing out the various cultures and understanding that, and then working with anatomy, physiology, with maybe dissections, etc. And so it really just gives way to people with all kinds of learning abilities to be able to see and feel and touch and really participate in that. So it was part of education requirements in California, and it was not asked by our California program directors to address this at all. They have a very robust science departments that support their nursing programs, and the laboratory component is something that they think is appropriate. The reason that we brought this to the board in November of last year was because of the endorsement, the reciprocity, the students that are educated outside of California that don't have that requirement coming into California and getting this essential roadblock saying that because you don't have lab, you cannot be licensed as an RN here. So this was a suggested carve out, as Heather put it, to allow for those nurses who are already licensed in another state, who are already practicing, to not have to go back to school, with the caveat that they did take a micro, they did take anatomy and physiology, and they did pass, but that the only thing that they were lacking was the laboratory components, but that they have since practiced without any adverse effects, essentially showing that missing that lab component did not cause any unintentional consequences.
So essentially what we're saying with this, if you're practicing for 2 years, it doesn't matter whether you've had it or not. You can get a license in California without the lab component if you've been practicing for 2 years. Is that my understanding of this?
It's without the lab component. It is not without those coursework. The coursework
I understand
must still be completed.
I understand coursework, but I'm talking about the lab component of it. So we're saying with this, if you've been practicing for 2 years and it doesn't seem to be an issue with your practice that you didn't have a lab, then that's okay. You can come here and not have the lab.
Yes, that's what the board voted to look into and get language started back in November. That was the ask of our board, yes.
Betty, this is Mary. I think your question is excellent about if we're going to waive it for, these, and it's not that many. Well, I mean, how many is it, Laura? You said hundreds? I know we've received some emails from some. It's nurse practitioners been practicing for 15 years who can't get licensed in California because when they went to nursing school, they didn't have the lab portion of microbiology. And for that person to then now have to re-enroll in a course and take microbiology and a lab when you've already been practicing successfully for years just doesn't make any sense. I think that calls a greater question to maybe go back again and say, if it's not that important in Virginia or wherever this person was, and I think the last one I recall was in Virginia, And maybe we are, maybe we don't need to make it a requirement here in California. But in the meantime, to me, to tell someone they either can't practice or they need to go back to school when they've already demonstrated that they can, perform successfully as a nurse, I don't think that makes any sense. So I support this.
All right, any other questions or comments from the board? We have no further questions from the board or comments. Is there any questions or comments from the audience? No questions or comments from the audience? Mary, is there any other questions or comments on your end?
No other.
Okay. Mark, can you open it up for public comment, please?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Kathy Hughes would like to make a comment. 1 second, please. Go ahead, Kathy.
Thanks, Mark. This is Kathy Hughes. I'm a registered nurse and the executive director of the Nurse Alliance of SEIU California. We represent about 35,000 registered nurses here in the state. We've been involved in this topic for many, many years, recognizing the pressure from the legislature and other stakeholders regarding the licensure or the endorsement from out-of-state nurses. Our concern has always been creating a two-tiered system where our new grads and all of our existing registered nurses have lab components in these areas, and out-of-state nurses do not. This looks like a little bit like a compact state agreement, but not quite. But I'm a little question about the rationale behind choosing 2 years. I know that there may not be an answer to our question, but why 2 years what's the rationale behind that? Because it's still a little bit concerning that a nurse can practice for only 2 years. It's not a great amount of time. It's not 15 years. And just doing justice to our new grads and our existing nurses that have taken those labs historically. Thank you.
Thank you for your comment. There are no other public requests for comments on the WebEx. Are there any public requests for comments in the HQ2?
There doesn't appear to be any questions or comments from HQ2.
Board Member Fagan in San Diego, are there any public requests for comments?
No requests here.
Thank you. There are no public requests for comments in all 3 areas. Would you like me to close this window?
Yes, please. Thank you. So Heather, I have a motion in front of me.
Yes, so the possible
For
motion.
item 5.2. The motion is approve the proposed regulatory changes to add section 1410.5 to Title 16 of the California Code of Regulations to read as shown in the board materials with the following modifications as discussed in this meeting. Direct the executive officer to take all steps necessary to initiate the rulemaking process, including submission of text to the director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review. Authorize the executive officer to make any technical or non-substantive changes to the rulemaking package. Notice the proposed text for a 45-day comment period, and if, after the 45-day public comment period, no hearing is requested and no adverse comments have been received, adopt the proposed regulations as noticed, and authorize the executive officer to submit the rulemaking package to the Office of Administrative Law, making any technical or non-substantive changes needed to the proposed regulation to complete the rulemaking process.
I'll second that.
Okay, we have a second.
This is Reza. Can I real quickly clarify two things? One, first of all, just as a general point, there was a document a few minutes ago that was provided to each of the board members. I just wanted to clarify for our public, that was just a copy of the slides that are being presented on the WebEx, so it's not something that is not otherwise available to the public. Also, in the proposed motion that was just stated, it had a space for any changes that were discussed during this meeting. And so far, I don't think that any changes to the proposed text were suggested. So that would probably be nothing as far as that goes.
All right, we have,
Go ahead, Betty. Perhaps it's me, but I still am not clear about this proposal about the labs. If we vote this down, then we would go back to that everybody that came had to have the lab. Is that my understanding? If we vote this to accept it, then we're accepting that if you have 2 years, then you don't have to have the lab. I'm just not clear in my mind what we're going to be voting on, and I mean, I would like to see the thing out altogether about the lab, but I don't know that I can make a proposal of that instead of what we have on the table.
So I can try to clarify.
Okay.
You're correct as far as your understanding of this regulation. As far as getting the lab requirement out altogether for California-educated nurses, that's something that you could propose for a future agenda because it wasn't specifically part of this. But that's another issue that can be taken up. But as far as what you said with this package, that's correct. So
okay.
Endorsement applicants, again, just to be clear, endorsement applicants could be exempt from the lab requirement if they have 2 years practice in good standing in their home state. California initial licensure applicants would still be required to take the lab components.
I'd like to add, I'm comfortable with the 2 years. Betty, I totally agree with you. I think maybe we should go back and Lori, I know your team's doing a lot of good work saying how does the requirements in California compare to all the other states so we can really understand where we sit. But in this situation, the cases, all the ones that I've seen, having them go back and take this lab would provide no additional value that I could see or any protection to the, people in California. And 2 years feels comfortable to me because that's the point at which nurses are eligible. I think in every professional certification that I'm aware of, you're eligible to sit for that professional certification, whether it's a CCRN or any certification. So that clearly to me is an indication that that this person is fulfilled the the level of experience to be certified in their field, which I think is a good proxy for they shouldn't have to go back and do this lab.
Patricia?
Yeah, thank you very much. So
Tricia,
the way I suggest this.
Is your microphone on?
It is. I've got the green light.
Okay, sorry, I apologize.
Thank you. That's fine. You know, we're going to be going out to the rulemaking process, which means we're going to suggest that it's 2 years, but the public is going to have lots of opportunity to say it shouldn't be 2 years, it should be 18 months, or it should be 36 months. So I am going to support this motion knowing that the public and advocacy groups will have an opportunity to comment, and we're going to then see this again, and we'll have a chance to have this conversation. So that's the way I'm looking at this.
Thank you.
Yes, they will have 45 days for a comment period. Okay. Any other questions or comments from the board? Any other questions or comments from HQ? All right. We can go ahead and take the vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan votes yes.
Thank you, Mary. Elizabeth Woods.
Woods, yes.
Jovita Dominguez.
Jovita votes yes.
And Tricia Nguyen.
Nguyen, yes.
Thank you, Tricia. All right, moving on to item 5.3, consideration of public comments, discussion, and possible adoption of modified proposed regulatory text to amend California Code of Regulations, Title 16, Section 1426, required curriculum. Heather?
Thank you. So that same section 1426 that requires the courses, that also has a minimum direct patient care clinical requirement. The proposal before you in your materials today would add a new subdivision H to 1426, which proposes that 500 hours is the minimum amount of supervised direct patient care clinical hours required to complete a nursing program, and that these hours may be exceeded. Additionally, a minimum of 30 hours of supervised direct patient care clinical hours must be dedicated to each nursing area as specified in 1426 subdivision D that already exists. The current language in G2 creates some uncertainty apparently. It currently states that 75% of clinical hours must be in direct patient care. It does not provide clear enough guidance as to the minimum number of hours required, because each course can have a differing semester or quarter unit and hour requirements. It also doesn't specify the minimum number of clinical hours of direct patient care experiences dedicated to each nursing area. And I will defer to Lori, who has some other examples of that, but this text would add a new subdivision that specifies that 30 hours and the 500 direct patient care clinical hours. And if you approve this section to go forward, again, we would move this forward to a notice and comment, and there would be 45 days of public comment, et cetera, and so forth. And I believe there is also a motion in your materials, or I can read one for you if you'd like. Thank you.
Thank you, Heather. So as I understand, the total amount of hours would be amended to 500. Heather?
So that would be a minimum 500 direct patient care clinical hours, and with a minimum of 30 hours in supervised direct patient care clinical hours dedicated to each nursing area specified in the current subdivision D. And there's a number of those areas specified.
Any questions or comments from the board?
Rick, can you provide us some background on where the 500 hours came from?
Yes.
I mentioned that in the past.
I pulled up some information from NCSBN, And NCSBN asked on a survey out to the different boards of nursing what if they had minimum hour requirements. And the largest amount of the minimum hour requirements came back from 500 to 700 hours. And so that was the starting point, is to look at 500 to 7 hours, because we would be 700, sorry, we'd be in alignment with the majority of our programs, of our other boards of nursing. And then taking a look at what our current curriculum approval is, the California State University system offers semesters on a 15-week semester. We require 18 units. 18 units in a 15-week semester ends up being a total of 810 hours required for clinical experiences. Our current regulation says 75% of those 810 must be in direct patient care. It also gives a carve out for a fundamentals course, and some fundamentals courses can be scheduled at 2 units or 4 units. And so if you did a 4-unit fundamentals course, you would subtract off the top of the 810. You would now only require, you would subtract off 180 of the 810, because 180 is 4 units. So you'd be down to 630 hours. So with 630 hours, we saw, just by taking out that provision, that left us where we were about. And then if you multiply that out, the 810 to 75%, which was our current, that brings it down to 607.5 hours as well. So what we realize is that with our current regulation at 75% for CSU systems who offer a semester, 15-week semester, they're already at over 600 units, 600 hours, but not close to the 700. So we did not want to increase the requirement, but we wanted to establish a baseline. The reasoning for establishing a baseline is to go off the NCSBN studies. The NCSBN studies said that if they establish a baseline of 600 hours, that simulation at 50% is appropriate. And I know that that's been an ask from our program directors for many, many, many years, but our board has not established a minimum direct patient care requirement to be able to allow for a 50% sim or any type of that. And then really taking into consideration what has happened over the last couple of years, when we went to 50% in simulation for med-surg and Jerry, and only 25% direct patient care for OB, peds, and psych mental health. And that was to allow the programs to be able to get their students through COVID times, because they did not have access to clinical sites. And so that's been a huge, huge outcry from our program directors, just really stating how difficult it is for them to find clinical sites and how difficult it is for them to get their students to progress and graduate. So they're wanting that additional flexibility. So pulling all the numbers, looking at traditional curriculums, looking at the standards from other boards of nursing, it was suggested that we go to 500. I brought that out to a stakeholders group where we met with COADN and CACN, and they said that 500 was absolutely something that they could support, and that they were very happy that the board was making movements to go to 500 hours. So that is how that came across. We looked at NCSBN, we looked at what our current requirements were, we looked at what the CSU systems did as an example. We brought it out to a stakeholders group and we received feedback, and that is where we're at with the board.
Thank you, Lori.
You're welcome.
What would be the breakdown of those 500 hours? How would that look for the different areas?
So with the curriculum design right now, the board does not have any requirements for hours in each one of the areas. So if a school wanted to put a half a unit course as med surg and say, we're just going to teach, and this is a very extreme example, this would never happen, but I didn't want any school to think that I was talking about them specifically. But if they chose to do med surg, they could develop their course to do a half a unit clinical to accommodate a med surg course. That half a unit clinical would be 22 and a half hours in a laboratory setting. And then with our current requirement of 50%, we can multiply that out, and they would only have to be in front of a patient, taking care of a patient for 16.875 hours. And that would meet our current requirement because we do not have a standardized curriculum. And in fact, we only require 18 units in totality for the entire nursing program. We do not require any unit specifics for each one of the courses. We do, however, have the statement that says that 75% of those hours must be in direct patient care for each one of the areas. So it does make it where if they have a half a unit course that they must be in a clinical setting for 16.875 hours. However, when you look at what happened over COVID, they dropped the specialty areas now to only requiring 25% to be in direct patient care. So if you have a program that has a geriatric course that they offer at half a credit, that is 0.22, that is 22 and a half, and you drop I'll use psych as an example. Use psych an example, and it's only 25%. So what you're saying is you can prepare a student to graduate school, be prepared as a nurse by only working 5.625 hours in front of a patient, taking care of them as part of their clinical prep work for graduation. So this, because of the ambiguity between curriculums, because there is no standard across curriculum, the discussion was to establish a minimum hour requirement in each one of the content areas. The content areas in 1426 are med surg, geriatrics, obstetrics, pediatrics, and psychiatric mental health. So at this point, the way that this regulatory language is written and proposed to you guys, it would require 30 hours to be in direct patient care in each one of those areas. Some of the comments that we heard in when reaching out and talking to stakeholders was that 30 hours was a difficult number to achieve. We had started at 60, thinking that 60 hours was an appropriate starting point. They said they were not able to make that 60 hours would absolutely stop them from progressing and graduating students. They said that they're not making specialists, that they're preparing generalists. And so those were some of the comments heard. Then I did reach out to see if this could be amended. It was amended before coming to the board to drop down to 30 hours. And this is where we're standing right now, being presented to you guys to ensure that in a 15-week semester, that a student must complete 30 hours. And so if you're doing a 6-hour clinical day, that would be 5 weeks of clinical, doing clinical 1 day a week for 6 hours in a 15-week semester. And that would then allow that student to be prepared to move through that course and successfully complete it if they were able to pass the clinical and the theory components together.
I was just commenting to President Trujillo that this is Jovita Dominguez, but I understand that like the LA area, the San Diego area has a lot of hardship on finding placement for clinical hours. And I mean, I support this, but I have a hardship because since I do teach at Hartnell, we're very blessed to not have that issue. And I see the struggles that the students have, the average student. Not all students can excel, but I see the difference in the hours that they put in. And as a practicing nurse at Salinas Valley, I see the difference from other colleges that do less hours than Hartnell, but it's something that puts a hardship on the employer to get that licensed nurse to a, practicing. So I see both sides, but it's a struggle. We each have our own beliefs, and and we also do want to have safe nurses out there in California. And I know this is not the same topic, but, I know that Vice President Fagan and Betty Woods have an issue with the lab component to anatomy and that. So I personally think that California does a great job asking for the lab in those anatomy and microbiology, because it puts the pieces, the puzzles at the bedside. And that is my personal opinion on this subject. But I totally understand, the bigger cities have more of a struggle, which I know that a lot of our board members, when we're accepting increases in those big cities, I know it's really hard for us to say yes.
It is, and the one thing just to make note on the way that the regulation is proposed here is that it's at minimum. It is not a maximum. So the individual schools could choose to offer more direct patient care. They are not limited with that. And so it is a minimum direct patient care that we are regulating, very similar to what we have in the past, which in 1426 right now says at a minimum 75% in direct patient care. And so there were many schools that would do 90% direct patient care. We had a school a few years back, I remember LA City College, they did 100% in direct patient care. They didn't offer any simulation. It was not needed. We do an annual report with the schools, and routinely, until the outbreak of COVID, it was not a consistent usage of even the 25% in simulation that was allowed for. So schools are incredibly resourceful. They've been able to get clinical sites. They've been able to get their students through. And when they have the opportunity to do more direct patient care, they do. And so that's always a really great thing. So setting a minimum really just kind of works with the curriculum that is kind of different. And I did hear that there were people that were using half a unit in specialty areas, and a half a unit on a 15-week semester is only 22 and a half hours required. And then with our current regulation, 75% of that is only 16 to 17 hours. With the emergency order that activates the law that you guys understand as AB 2288, which is now 2786.3 of our Business Professions Code, when it falls in a nursing specialty area that they outlined at 50%, that requires the person only to complete 11 hours. And we're now saying that should be 30. That requirement was specifically written for the state of emergency. And we understand that in state of emergency, having that flexibility is key. But we're now trying to set a new norm for when we're not in that state of emergency. And the requirement, if it was a specialty that was able to get dropped down to the 25%, that went so low as 5 hours in a clinical setting to get our students to progress and graduate. And what we're hearing from the various organizations that offer new grad programs is they don't know where to start their baseline at. And so if we can get something established in our regulation that says this is a minimum requirement and this is a minimum requirement throughout each one of the specialty areas as well, then the new grad programs know that that is their starting point. And Jovita, to your point, where you mentioned, you know, it's hard to get these nurses that are now licensed to all be competent and through these programs to be able to take care of patients. And that's where it's key to have education working with workforce, to have academia get feedback from workforce and workforce to get feedback to academia, so that we're preparing our nurses to take care of our patients safely, and working with the idea that the education that is granted in an academic situation prepares them to be safe and competent, and that the institutions that hire them after they become licensed continue to support them through that onboarding period, continue to validate competencies and bring them up to the standard so that everybody is kind of safe. I mean, that's really the whole purpose of our board is protection. And so having a baseline, I think, is really appropriate, and is a start of a new way to look at education and academia in nursing here in California.
Thank you, Lori. Tricia?
Yeah, thank you very much, Lori. Again, I look at this as a starting point, so this will be going out. It seems very fair to me, but if it's not, we're going to hear about it. So, you know, I would be supporting, you know, moving this regulation forward and allowing schools to come in and say, you know, it's impractical, or it's too high, or it's too low. So thank you.
Any other questions or comments from the board? Seeing as there are no questions or comments from the board, I would like to move to public comment before a motion is put out.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Kelly Butler would like to make a comment. 1 second, please. Go ahead, Ms. Butler.
Lee Butler from Modesto Junior College, and thanks for the opportunity. I think it is great that the BRN is looking at setting minimum hours for the direct patient care, but for our program, this poses a problem to have 30 units in each of the 5 content areas. Particularly our geriatrics course, which is a half-unit course. At our college, a half-unit course is 27 hours. So our total clinical hours for geriatrics is less than the minimum requirement for that content area. So this would require us to make a curriculum change unless there's some creative way to get the geriatric content perhaps part of the med-surg hours. In the med-surg clinical areas could be considered geriatrics, but our students have been successful with this 27 hours total in geriatrics, and so I would just like to bring that to your attention, that this poses a concern for us, and maybe some other considerations can be made. Thank you.
Thank you for your comment. Lynette Apin would like to make a comment. 1 second, please. Go ahead, Ms. Apin.
So I'm Lynette Appin. I'm the Dean of Nursing at Evergreen Valley College and the President of the Northern Region of the California Organization of Associate Degree Nursing, COADN. On behalf of COADN, I'm sharing our support for BRN's proposal of the minimum direct patient care hours of 500 in total. I think just to echo my colleague Kelly Butler, who just shared from Modesto, the area that we still would like to have some conversations around are the minimum direct patient care hours for the specialty areas. We appreciate the consideration of going down to 30 hours, but we do feel that that may still pose some challenges and would request that the board consider going down to 20 hours for each of the specialty areas and or just setting the 500 minimum an hour requirement and allowing the nursing faculty and program directors to determine the best, based on the quality of their instruction and their curriculum, to determine how best to lay out these hours. And then I also just wanted to validate what Loretta Melby shared, that this is a minimum requirement, and because all nursing pre-licensure programs are requiring 18 units minimum of clinical, again, that's 810 hours at a minimum. So that leaves 310 hours that are done either through direct patient care, sort of in addition to the 500, or utilizing evidence-based strategies that we know work in education, such as simulation. Thank you so much for your consideration.
Thank you for your comment. Dr. Daniel G. Ortiz Jr. would like to make a comment. 1 second, please. Go ahead, Dr. Ortiz.
Board, thank you for the opportunity to comment on this exciting topic. I want to appreciate Loretta's support and report on the use of 50% simulation where we've been historically, especially in light of the last 2 years, and also my colleagues that preceded me. I am a member of the California Simulation Alliance, and we really would like to provide some overview and assistance, guidance in any way possible in identifying the 50% simulation, understanding that all sim programs are different, all nursing programs are different, but establishing a standard of what the expectations are for pre-licensure students and then those in the advanced practice role. So there's a lot of exciting new information coming out, but we have to follow what the evidence is showing. And if the students are able to effectively take care of patients following preparation and simulation. In our region, in Imperial Valley College, we have utilized simulation because we are regionally displaced. So this is an exciting conversation and one that I would support moving forward. Thank you very much.
Thank you for your comment. Robin Nelson would like to make a comment. 1 second, please. Go ahead.
Good morning.
Go ahead.
Thank you. I'm too many things on the screen. Good morning. I'm Dr. Robin Nelson. I'm the Dean of Nursing for CNI College in Santa Ana, California. I'm also the board member at large for the California Association of Colleges of Nursing. And CACN, in conjunction with COADN and my colleague Lynette Apen, are very grateful for the consideration, the forward movement, the flexibility, although we would, as my colleague from simulation said, we would certainly like to have a simulation standard, but we just want to thank the board for the opportunity to look at options and flexibility. So thank you.
Thank you for your comment. Board President Trujillo, there are no public requests, more public requests for comments in the WebEx. Are there any public requests for comment in HQ2?
I have a question for Lori. So I've heard in public comment just now the possibility or request to leave it up to the schools to determine how the 500 hours would be required in their curriculum. how would we guarantee that there would be the right amount allotted to each area? Let's just say geriatrics, OB, pediatrics. How would we guarantee that that was being met?
We are only allowed to work within the regulatory and statutory components within the Nurse Practice Act. So if it is not delineated out in regulation, we cannot enforce that. Which is why the 30 hours was the minimum requirement added in to address each one of the content areas. Without that piece, we would not be able to ensure that there's a minimum. I did hear the comment that says that they currently at their half a unit are using 27 hours for geriatrics. That's a conversation that can be had. It may be something that we can do within 1426 and continue to revise that. We can look at adding, combining, med-surg and geriatrics into one specialty area. It is very, very commonly noted that the majority of any medical surgical unit, any healthcare organization, the majority of the patient population is going to be near the geriatric age or at the geriatric age. And so having that as a separate specialty might be something that we look at, to just have it, as she suggested, a med-surg geri combo. And that's something that we can absolutely do. We could also do, if the board required 30, did not address the 5 content areas and left geriatrics out to be separate, we could have them do a curriculum plan where they showed that the 3 remaining hours that they were lacking in geriatrics was embedded in their medical surgical course. It's a common practice for many academic institutions to have geriatrics as a thread throughout their curriculum and not have a separate geriatric course. So there are many, many ways that we can work with that and handle that. I think that, again, as Tricia Wynn said, it's a starting point. I did get a reach out on email that Saskia Kim is trying to make a comment and it's not working for her. I'm not sure if the board moderator can take a look at that. Oh, okay. Thank you.
Is Saskia on?
No, we have 2 comments. There's people before her. She submitted 4 requests, so I just kept removing the oldest.
Not a problem. So we still have public comment happening right now. Is that correct?
Yes.
Okay.
I was just waiting for you to finish.
Let's finish up public comment.
Kathy Hughes would like to make a comment. 1 second, please.
Hi, this is Kathy Hughes, registered nurse with the Nurse Alliance of SEIU California. And we'd just like to show our appreciation for setting the minimum number of hours. We think that that is a great idea for all the reasons everyone, especially Loretta Melby, has pointed out in the past meetings why that's needed versus percentages, because we will eventually be out of a state of emergency. And I don't think that we need to continuously lower our standards regarding, simulation, 50% of simulation. How do you measure that? That kind of thing, just because we've made it through. It's similar to when I was working at the bedside and I might have been put out of ratio for whatever reason and no one died. And so it's a way to justify the fact that, ratios aren't necessary. I think that we need to have these standards in place. And still some questions around the 30 per area. I'm not quite sure about that. We'll have to do a little bit of research, but do appreciate the proposed minimum standards of hours. Thank you.
Thank you for your comment. Saskia Kim would like to make a comment. 1 second, please. I'm trying to unmute you, Saskia. I'm sorry, I'm sending you a request to unmute. If you're on your phone, I think you have to hit pound or something. I'm not sure. I'm sorry, Saskia, if you can't unmute yourself, if you want to type in your comment, I will read it. Mio Minato would like to make a comment. 1 second, please. Go ahead.
Thank you for the opportunity to give my feedback. I think it's important that you set up the minimum requirements, but it sounds like from all the questions, the numbers that are being proposed might need to be looked at more carefully, because when you set a minimum number, you're not saying for which, you're setting for a total number of units or hours, and also you specify specialty units or specialty areas. And the percentages for simulation experiences came about because at the time the regulations were developed, that was a new teaching strategy that was being developed. And the survey of all programs were done at that time to determine how much time of the actual clinical 18 units of clinical hours were being used in simulation. And that's how 25% came about. After this survey, then the actual simulation study came about, and further studies of simulation resulted. Consequently, now it's being shown that possibly 50% of simulation will give sufficient or adequate clinical time, but there are still people who believe that direct patient care is the best. And it's just my opinion that the numbers being presented right now to make the changes in the regulation may be premature, and more discussion might be needed to address all of the concerns that are being raised by all parties: curriculum, direct patient care, and the simulation time. I wonder if you might be able to kind of table this and get additional input, then come back and make a more concrete regulatory change languages that would address the concerns how the 510 hours or whatever hours came about. Because right now, 18 units is your minimum clinical time. And that includes both simulation time and the actual direct patient care time. And it is up to the individual curriculum at the.
Thank you for your comment. Victoria Bermudez would like to make a comment. 1 second, please. Ms. Bermudez, I'm clicking on both of your joins. You can unmute on either one.
Can you hear me?
Yes, there you go.
Okay. Good morning, Vicki Bermudez from the California Nurses Association. Thank you for the time today. I'd like to quickly raise CNA's concerns about the proposal to require that a minimum of 30 hours of direct patient care clinical hours be dedicated to each nursing area specified in Section 1426D. This is a significant decrease from the current regulation. For example, as noted in the chart in the agenda item summary, a 2-unit clinical course in pediatrics would equal 67.5 hours of direct patient care under the current regulation. Yet the proposal before you today would allow for only 30 hours of direct patient care experience. That's 2 hours per week. The Society of Pediatric Nurses has expressed great concern about the trend toward reducing pediatric clinical hours in pre-licensure nursing program, calling it a, quote, threat to the preparation of future clinicians and to the children in their care, and it neglects the specific health challenges of infancy and childhood. In fact, a survey of the members of the Society of Pediatric Nurses recommends that a minimum of 61 to 80 clinical hours of direct patient care is necessary for nursing students to achieve the Society's recommended pediatric pre-licensure competencies and to be able to care for pediatric patients. CNA believes in using increased simulation to replace minimum clinical hours spent with patients threaten safe patient care by increasing the risk of decreased clinical competency. The board's statutory public protection mandate provides that the BRN's primary role is to protect the public. Every patient in California who receives care from a nurse graduate of a BRN-approved nursing program expects that the nurse taking care of them is qualified to provide care across the lifespan and is safe to practice. Health facilities rely upon and who are prepared to practice upon graduation and who have gained diverse clinical competencies that prepare them for employment with mixed patient population. But simulation cannot replace mentored experiential time with patients in the actual environment of care. Students should be educated so that they are able to develop skills and critical thinking ability rather than simply being trained in tasks. Protection of the public requires direct care experience. Finally, if the board decides to include a 500-hour requirement, it is imperative that a minimum number of clinical hours in each concept area be directed to direct patient care. The board should not stay silent on this. Otherwise, the board will be creating a loophole that would allow a program to use simulation for a course's entire clinical component, as long as the total number of direct patient care clinical hours was 500 overall. For all these reasons, CNA recommends that you heed the recommendations of the Society of Pediatric Nurses for 61 to 80 hours before reducing direct patient care clinical hours in each nursing hour to only 30 hours. Thank you.
Thank you for your comment. Dr. Brenda Chan would like to make a comment. 1 second, please. Dr. Chan, go ahead, Dr. Chan.
Thank you, moderator. Can you hear me?
Yes, go ahead.
Thank you. This is more for a clarification question. I put in the comment box. Will this change the 18 units theory and 18 units clinical for the minimum requirement, or it will just allow simulation to be used for meeting the 18 minimum clinical units requirement? Thank you.
Thank you. I can answer that. It does not change the 18 unit requirement. That is something that is standard in the set. And then for additional clarification, the board does not have any regulatory authority over simulation. So it only sets currently the direct patient care hour requirement in regulation. This would just further clarify that. And each one of the academic institutions would be able to complete the remaining hours in another modality, which could include simulation if they had the resources at their school to support a robust simulation program. So that would give the individualization back down to the school level, where the board would remain silent on whether or not simulation can be used and continue to regulate the section that mandates direct patient care, because that is what our board has in the past stated repeatedly that the direct patient care is really the optimum way to prepare a student to be able to transition into a new grad and become a licensed RN.
Thank you so much.
Thank you for your comment. Saskia Kim would like to make a comment. 1 second, please. Go ahead, Ms. Kim. Ms. Kim, I've sent you a request to unmute yourself.
Mark, can she type in her comment?
I asked her to. She did not. She wanted to speak, but she can't unmute herself for some reason.
Mark, I was just contacted by Saskia Kim, and she let me know that she does not need to be unmuted, and that Vicky was able to deliver her comment.
Oh, okay, perfect.
Thank you.
Thank you. There are no more public requests for comment on WebEx. Are there any public requests for comments there in HQ2?
Any other comments or questions from the board? No? Any other questions or comments from our audience? No? No further questions or comments.
Okay. Board member Fagan, are there any requests for comments in San Diego?
None here.
Thank you. There are no further requests for comments. Would you like me to close this window?
Yes. All right. I would like to make a motion to, and Heather, you can give me a hand on this, approve the proposed regulatory changes to amend Section 1426 of Title 16 of the California Code of Regulations to read as shown in the board materials. I don't believe there were any modifications. Direct the executive officer to take all steps necessary to initiate the rulemaking process, including submission of text to the Director of the Department of Consumer Affairs and the Business, Consumer Services, and Housing Agency for review. Authorize the executive officer to make any technical or non-substantive changes to the rulemaking package. Notice the proposed text for a 45-day comment period. And if, after the 45-day public comment period, no hearing is requested and no adverse comments have been received, adopt the proposed regulations as noticed and authorize the executive officer to submit the rulemaking package to the Office of Administrative Law, making any technical or non-substantive changes needed to the proposed regulation to complete the rulemaking process. Do I have a second?
Jovita seconds.
Since we've already opened for public comment, we will take the vote. Dolores Trujillo votes yes. Vice President Mary Fagan?
Mary Fagan, yes.
Elizabeth Woods?
Woods, yes.
Jovita Dominguez?
Jovita, yes.
And Tricia Nguyen?
Nguyen, yes.
Okay, the motion carries. We're going to reorder the agenda. This is going to be informational only, and then we will break. We have a hard stop from one of our board members for lunch, and this is item 6.4, sorry. This is a budget discussion, which is informational only, no vote.
Moderator, can you elevate Suzanne Balkas, I think?
Sorry, do I also need to elevate Renee?
Yes, please.
Okay. Suzanne, you're elevated, and Renee is elevated. Okay.
Hi, good morning, everybody. Thank you for allowing us to present today. My name is Suzanne Balkas, and I am a budget analyst with DCA Budget Office. I am here to present the board fund condition statement that we currently have FM9 projections included into. Please refer to agenda item 6.4, starting on page 57 of your meeting material. This is your fund condition. Could you please go to page 57? So this is going to be your fund condition, and we have an actual 2021 beginning balance of about 47.5 million, with prior year adjustment of negative 530,000. That gives us an adjusted beginning balance of about 47 million. We have an overall revenue of about 71.7 million, and a loan from the board to the general fund of about 30 million, which is projected to be returned in 23-24, and a total expenditure of $54 million. That have a fund balance of 34.8, which is about 6.9 months in reserve. For current year, which is 21-22, we have our beginning balance of 34.8 million, and we have a projected total revenue of about 81 million coming in. We are tracking an overall projected FM9 expenditure of about 61 million. With that expenditure and revenue, we currently have a fund balance of about 55 million, which give you about 10.3 months in reserve. Budget year is based on governor's budget, and budget year +1 is based on realized. And we have no concern for this fund. If you have any questions, please let us know.
Tricia?
Thank you very much. I'm just wondering if there was anything in this budget that's, significantly different than was anticipated, anything that we should be paying attention to.
I honestly did not see anything that is different. Just one thing is the revenue is a little bit different, but that is the only thing that that is different than prior years.
Any other questions or comments from the board? Mary, any other questions or comments on your end?
No, just the projections for the revenue going forward. Is that just based on the current run rate, or is there some other factor that was used to determine projected revenue?
So this is based on the governor budget, and it's based on a workload, but this one is estimated about last year. So of course, this one is going to be changed. So it's going to be changed soon because we're going to be asking for a new workload, and that number is going to be changed. But we have to keep these numbers based on the governor budget.
Okay, thank you.
Any other questions or comments? There are no questions or comments on our end here in HQ2. This was informational only. So at this time, we will open for public comment.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give reminders as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." There are no public requests for comments in the WebEx. Are there any public requests for comments at HQ2?
I don't see any requests for questions or comments.
Thank you. Are there any public requests for comments in San Diego?
There are no public requests for comments in San Diego. Thank you.
Thank you. There are no public requests for comments in the 3 areas. Would you like me to close this window?
Yes, please. Thank you. At this time, we will break for lunch. We will come back. It is 12:01 now, so at 1 o'clock.
Thank you. Board moderator, can you put a slide up on our screen letting people know that we will be back and
I'm
resume
sorry,
our
we're going to
board
break
meeting at 1
until
o'clock?
1:15. We're going to break until 1:15. Just clarification. Everyone have a good lunch.